Before this story begins, one thing. When the moment hits, drop one word in the comments. Whatever it did to you. I read every single one, every time. Now, what follows is a lecture. It was delivered by Dr. Vel-Ka-Rath of the Galactic Medical Institute's Combat Medicine Department to a class of 43 third-year medical students, approximately 4 years after the events the lecture describes. The lecture is part of a module called Biological Resilience and Clinical Expectation. It is the last lecture of that module. Dr. Vel-Ka-Rath has taught this module 9 times. This case study has been part of every version of the module. In the 4 years since the events described, she has added to the case study each year as her understanding of what happened has developed. She has never been able to deliver this lecture without stopping at a specific point. The students always notice the pause. This is the transcript of the 9th delivery. The pause is at the same place it always is. Good morning. Settle down, please. I know it is the last lecture of the module, and I know some of you had a long night. Stay with me. This one matters. I say that about most of the lectures in this module, and I mean it about all of them, but I want to be specific about why I mean it today. The case we are going to discuss this morning is the case that changed my clinical practice more than any other case in 23 years of combat medicine. Not because it introduced me to a new technique. Not because it demonstrated an error in my methodology that I needed to correct. Because it showed me something that my training had not prepared me for, and that I think your training has not prepared you for either. I am going to spend this lecture trying to prepare you for it. Whether I succeed depends on whether you are paying attention, so I will say one more time. Stay with me. The case is documented in the literature as Human Resilience Incident 7, which is an extraordinarily bland name for something that was, when I experienced it, one of the most disorienting events of my medical career. I was present. I want to be clear about that at the start of the lecture, because the case has been discussed extensively in the literature by people who were not present, and their descriptions are accurate as far as they go, and they do not go far enough. They describe the clinical findings. They do not describe what it was like to be in the room. I am going to try to describe what it was like to be in the room, in addition to the clinical findings, because I think both are necessary for a complete understanding of the case. Let me start with the circumstances. The engagement was a contested zone operation in the Kessel system. I was deployed as the senior combat medic for a joint species unit, 4 species represented, humans being one of them. My role was standard combat medicine, field treatment and stabilization for transport. The human casualty was brought to my position approximately 40 minutes into the engagement. His name was Sergeant James Okafor. He was 34 years old. Let me describe Sergeant Okafor's condition when he arrived at my position, using clinical language first, and then I am going to tell you what I actually saw, because those are different things and I want you to understand both. Clinical language. The patient presented with multiple penetrating trauma injuries, including 2 significant wounds to the torso, 1 significant wound to the left upper limb, and several minor wounds distributed across the body. Vital signs on arrival: depressed but measurable. Neurological status: conscious and responsive. Pain response: present and appropriate. Blood pressure: low but not critically so at time of arrival. Estimated blood loss: significant. Clinical assessment: the patient required immediate stabilization and urgent transport for surgical intervention. The patient's condition was serious but not immediately terminal. That is the clinical description. Now let me tell you what I actually saw. A man who should not have been conscious was conscious. A man who should not have been talking was talking. A man who had sustained trauma that, in any of the other 3 species I treat regularly, would have produced either unconsciousness or a shutdown of voluntary movement, was lying on my treatment surface making jokes. That is what I saw. He made a joke. In the first minute after I began treatment, with wounds that I am going to describe in more detail shortly, he made a joke about the quality of the enemy's aim. I did not know what to do with this information clinically. I filed it under Human Behavior Anomalous, will review later. I have been reviewing it for 4 years. I want to spend a significant portion of this lecture on the specific clinical findings, because the clinical findings are where the educational value of this case is most dense. I want you to take notes on this section. The torso wounds. Human torso anat. AMI involves a complex arrangement of vital structures protected by a rib cage that is less robust than comparable structures in most species you will treat. The wounds Sergeant Okafor presented with were in the upper and lower left quadrant of the torso. The upper wound had penetrated to a depth consistent with compromise of structures in the region. The lower wound was shallower but broader. In species with comparable vital structure arrangements, wounds of this type and location would typically produce one of two outcomes: loss of consciousness within 3 to 5 minutes due to a combination of blood loss and physiological shock response, or immediate shock response with cessation of voluntary movement. Neither of those outcomes occurred. The patient remained conscious and voluntary movement was maintained throughout the treatment period. I want to ask you to consider that for a moment before I continue. Not to accept it as a given, to actually consider what it means for your clinical practice. If your expectation is that wounds of this severity will produce unconsciousness and the patient remains conscious, what do you do with that information? Do you recalibrate your assessment of the injury severity? Do you recalibrate your expectation of the outcome? The answer, I am going to argue for the rest of this lecture, is that you do the second. You recalibrate your expectation. Because the patient is telling you something by remaining conscious, and your job is to listen. I am going to describe the treatment process and what happened during it, and I want you to pay attention to the sequence of events because the sequence is clinically significant. I began stabilization treatment approximately 4 minutes after the patient arrived at my position. Standard protocol: address the most significant wound first, establish IV access, administer pain management, prepare for transport. I addressed the upper torso wound. The patient said during this process several things. I'm going to describe what he said because what he said is clinically relevant. It is data about his neurological and cognitive status. He said in order: 1. Is it bad? I said. It is significant. He said. That means yes. I confirmed. 2. How long will this take? I said. Stabilization approximately 8 minutes, transport another 20. He said. I need to be back out there in 30. I said. That is not going to be possible. He said. We'll see. 3. Is the rest of my squad okay? I said. I do not have current information. He said. Find out when you get a chance. Not a command, a request, with a please at the end. I found out when I got a chance. 2 members of his squad were also at the treatment position. They were both in better condition than he was. I told him. He nodded and went quiet for approximately 40 seconds, which is the longest continuous quiet period in my notes on this patient. Then he said, "Good. Let me explain why I am telling you all of this. Because the conversation is not incidental to the clinical case. The conversation is the clinical case. A patient with those injuries who is having that conversation is a patient whose biology is doing something that your training has probably taught you to not fully account for. The upper limb wound. I want to spend specific time on the upper limb wound because it is the wound that produced the event that is the subject of this lecture. And that, in the 4 years since, I have thought about more than any other single moment in this case. The left upper limb wound was a significant trauma to the musculature of the upper arm, with associated compromise to the structural integrity of the joint at the shoulder. In most species I treat, this type of wound produces immediate and complete loss of voluntary function in the affected limb. The pain response alone is typically sufficient to prevent voluntary use of the limb even in species with high pain tolerance. I assessed the wound. I documented the assessment. My assessment was: left upper limb, non-functional, transport imminent. I communicated this to the patient. I said, "Your left arm has significant damage. Do not attempt to use it." He said, "Noted." I proceeded with the treatment. I completed stabilization of the other wounds. I administered the appropriate medications. I was preparing the patient for transport. The transport team was approximately 3 minutes away, and then the situation at the treatment position changed. I am going to describe what happened and I want you to focus on the sequence. An opposing force element reached the treatment position. This is a relatively uncommon occurrence in combat medicine, but it is one that we train for. My training protocol for this situation is, if possible, move the patient to a more secure position. If not possible, secure the position and call for support. I assessed the situation and determined that moving the patient was not immediately possible. His condition made rapid movement inadvisable. I called for support. The support response time was estimated at 5 minutes. The opposing force element was at the edge of the treatment position. There were 3 of them. I am not a combatant. I have a sidearm for personal protection. 3 opposing force personnel at the edge of a treatment position with a seriously injured patient and a non-combatant medic is a situation with a predictable outcome. I want to be direct about this so the students understand the context. I was not confident about the next 5 minutes. I was preparing to implement emergency protocols. And then Sergeant Okafor said, "How many?" I said 3. He said, "Okay." And then he sat up. I want to describe the sitting up specifically because it is the clinical center of this case, and because describing it accurately requires me to account for several things simultaneously. First, the clinical picture at the time of the sitting up. The patient had sustained the injuries I described. He had received partial stabilization treatment. He had not received the full treatment protocol. Approximately 2 minutes of treatment remained before I would have classified him as stabilized. His vital signs at the time of the sitting up were improved from arrival but still depressed. His left upper limb was, by my assessment, non-functional. His pain management medication had been administered, but was at a dosage calibrated for a patient who was not going to attempt physical activity. He sat up. He did this without assistance. He moved from a supine position to an upright seated position using his right arm and his core musculature. He then did something that I have included in this case study every year for 4 years and that I am going to describe as precisely as I can because precision matters here. He raised his left hand. The hand of the arm I had assessed as non-functional. He raised it to approximately chin height, and he cracked his knuckles. I want you to understand what that requires. Cracking knuckles is a voluntary action requiring fine motor control, specific joint manipulation, and conscious direction of muscular force in an arm that I had documented as having compromised musculature and structural integrity. He did it deliberately. He looked at it while he did it, and then he looked at the opposing force element at the edge of the treatment position, and he said 2 words, "My turn." I need to stop here for a moment. I do this every time I give this lecture, and the students always notice. I am going to take approximately 30 seconds, and then I am going to continue. I have been doing this for 9 lectures, and the 30 seconds has not gotten shorter. What I am doing in the 30 seconds is the same thing I was doing when it happened in the treatment position. I am trying to process what I observed against what I understood to be possible. They are not fully reconcilable, and they have not become more reconcilable in 4 years. The reconciliation is not the point. The point is that the irreconcilability itself is clinically significant. When a patient does something that you cannot reconcile with your assessment of their condition, that is data. It is data about your assessment. It is telling you that your assessment is missing something. My assessment was missing something. My training had given me a framework for assessing injury severity based on clinical indicators. The framework was accurate for what it measured. It was not measuring everything that was relevant. What it was not measuring was the patient's decision, and the patient had made a decision, and the decision changed what the clinical indicators meant. What happened next is in the official engagement record, and I am going to summarize it rather than describe it in full detail, because the engagement details are not the educational focus of this lecture. Summary. Sergeant Okafor engaged the 3 opposing force personnel who had reached the treatment position. The engagement lasted approximately 2 minutes and 40 seconds. I provided whatever assistance I was able to provide, which was limited. The transport team arrived approximately 4 minutes after the engagement concluded and found the treatment position secure. Sergeant Okafor was at the edge of the position when they arrived. He was standing. He was upright and standing on his own without assistance. His condition at that point was significantly worse than it had been before the engagement, which is what you would expect. He had spent 2 minutes and 40 seconds doing things that a person with his injuries should not have been able to do. The body pays for that. He knew the body pays for that. He did it anyway. When the transport team arrived, the first thing he said to them was, "Get the medic out first." He said it twice to make sure they heard. "I was not injured. I was fine." He did not know that when he said it. He said it because I was a non-combatant and he thought I might need to get out. First, I have been thinking about that for 4 years as well. I want to spend the remainder of this lecture on the clinical implications of what I observed, because I think the implications are extensive, and I think your training has not fully prepared you for them. The first implication is about pain. Human pain tolerance is documented in the literature, and the documentation is accurate in the sense that the numbers are correct. The numbers, however, do not capture the mechanism. Most species' pain response functions as a limiter. Above a certain pain threshold, voluntary function is significantly impaired. The evidence from this case and from other human cases in the literature suggests that the human pain response is not purely a limiter. It contains a component that the literature has begun calling pain-modulated determination, which is an accurate but somewhat sterile way of saying humans sometimes respond to pain by increasing voluntary effort rather than decreasing it. The mechanism is not fully understood. What is documented is the outcome. A patient in sufficient pain may have access to a level of voluntary effort that they would not have access to in the absence of pain. This is counterintuitive. It is also documented. I want you to update your clinical expectations accordingly. Second implication, the relationship between assessment and decision. Your assessment of a patient's condition is a measurement of their biological state at a given moment. It is not a measurement of what they will do with that biological state. A patient who decides to get up will attempt to get up regardless of what your assessment says about the advisability of getting up. Your job is not to tell the patient what they can do. Your job is to give them the best possible biological foundation for whatever they decide to do. This distinction matters. It changes how you prioritize your interventions. It changes what you say to the patient. It changes your relationship to the clinical outcome. Third implication, what I am going to call the intention variable. This is the part of the case that has produced the most academic discussion and the most pushback from colleagues who prefer their medicine to be more straightforwardly biological and less subject to what they call philosophical speculation. I am going to describe it anyway because I think it is real, and I think you need to know about it. In the 4 years since this case, I have reviewed the literature extensively. I have looked at every documented case of human recovery from significant trauma that includes sufficient data to assess the intention variable. The intention variable is this: patients who have made a decision about what they need to do next recover faster and more completely than patients who have not. This is not a universal finding. The literature is mixed. What the literature shows clearly is that in humans specifically, there is a documented correlation between expressed intention to continue a specific activity and the rate of biological recovery that supports that activity. The correlation is not perfect and the mechanism is debated. The correlation is real. What it means for your practice is, ask the patient what they intend to do. Not because you will honor all intentions. You will not. Sometimes survival requires overriding intention. Because knowing what the patient intends gives you information about their biological trajectory. Sergeant Okafor said I need to be back out there in 30. He said it 3 minutes after arriving at my position with significant injuries. I documented it as patient statement, non-compliant with medical recommendation. I should have documented it as patient has declared a recovery intention. This is prognostically relevant. In retrospect, it was the most relevant piece of data in the intake assessment. Let me tell you what happened after the transport. I followed up on Sergeant Okafor's case through the standard post-treatment documentation. He was transported to the surgical facility. where he received the surgical intervention his injuries required. The surgical notes describe the injuries as consistent with the field assessment, significant, requiring extensive repair, expected recovery period of 4 to 6 months. He was discharged from the surgical facility 11 weeks after admission. The discharge notes describe him as recovered beyond projected timeline. He was back on active duty 14 weeks after the engagement at the treatment position. 14 weeks. The projected recovery period was 4 to 6 months. He was on duty in 14 weeks. The surgical team's note on this outcome says, in the dry language of surgical documentation, patient demonstrated recovery rate inconsistent with injury severity. The note does not say anything further. I want to say something further. The recovery rate inconsistent with injury severity is not a statistical anomaly. It is not a random variation. It is a spec. If a human engaged in a specific biological process that our clinical frameworks have not fully accounted for. The process is intention and biology working together in a direction that standard assessment does not fully predict. I do not know exactly how it works. I know that it works. I know it from this case, and I know it from the literature, and I know it from 11 years of treating humans in combat medicine contexts. It works. And if you are going to practice effective medicine with human patients, you need to know that it works. I want to spend some time on the pain management data specifically, because it is the data point that has generated the most discussion in the literature and the most questions from previous cohorts of students. When Sergeant Okafor arrived at my position, I administered pain management medication within the first 2 minutes of treatment. The dosage was calculated based on the standard protocol for human patients, accounting for body mass and injury severity. The dosage was appropriate. By the pharmacological timeline for the medication I administered, effective pain modulation should have begun within approximately 8 minutes of administration. The engagement with the opposing force element began approximately 6 minutes after administration, which means the medication was not yet at full effectiveness when the engagement began. I have calculated this timeline many times. The calculation is consistent. He engaged under conditions of significant pain. Not pain that was being managed at full effectiveness. Significant pain. And this is where I want to bring in something from the literature that I find important for your clinical understanding. There is a body of research on what human subjects describe as their subjective experience of pain during high-stakes physical activity. The research consistently finds that human subjects report significantly reduced subjective pain experience during periods of what they describe as high focus or high stakes. The reduction is not pharmacological. It is not a product of endorphin release alone. The timing does not support that explanation. It appears to be a product of cognitive allocation. The human brain, when sufficiently focused on an external objective, allocates less cognitive processing to the pain signal. The pain signal is still there. The injury is still there. The human's conscious experience of both is reduced. This is not unique to humans. Similar effects have been documented in other species. What appears to be different in humans is the degree of reduction achievable and the conditions under which it is achievable. A sufficient external focus in humans can reduce the subjective pain experience to a level that allows function that the pain signal alone would prevent. Sergeant Okafor had a sufficient external focus. The external focus was the 3 opposing force personnel at the edge of the treatment position. I want to address something that comes up in the academic literature about this case and about human resilience cases generally, because I think it is a question you will encounter, and I want to give you my view on it before you encounter it in a context where someone else is giving you a different view. The question is whether cases like this one should change how we make clinical recommendations to human patients. Specifically, if human patients are capable of doing things that our clinical assessments suggest they cannot do, should we stop making clinical recommendations based on those assessments? The short answer is no. The clinical recommendations are based on what is advisable given the patient's condition. The fact that a patient may override what is advisable does not make the recommendation wrong. It means the patient has information that the recommendation does not have. The information the patient has is what they have decided to do. My recommendation to Sergeant Okafor was correct. He should not have engaged those 3 personnel. The engagement cost him significantly and extended his recovery period substantially. He engaged anyway because he had made a decision about what was more important than his recovery. That decision was his to make. My job was to give him the best possible biological conditions for that decision and to make the recommendation that would serve his long-term well-being. I did both. He made his decision. This is the tension in combat medicine. You treat people who are in situations where long-term well-being and immediate necessity are in conflict. Your job is to be clear about what you are recommending and why. The patient's job is to decide. And sometimes the patient's decision will be 2 words and a set of cracked knuckles. When that happens, your job is to be ready to continue treatment as soon as the 2 minutes and 40 seconds are over. A student in a previous cohort asked me, after this lecture, whether I thought Sergeant Okafor had made the right decision. I want to answer that question in this lecture because I think it deserves an answer, and because the answer illustrates something important about the relationship between clinical judgment and personal decision. My answer was, I do not know. I know the clinical cost. The clinical cost was an extended recovery period and additional injuries sustained during the engagement. I know what the engagement produced. The transport team arrived to a secure treatment position rather than an unsecured one. I know what might have happened if he had not engaged. I cannot know this with certainty, but the situation was not favorable. What I do not know, and what I want to be careful about claiming to know, is whether the decision was right in some absolute sense. Because that is not a medical question. That is a question about what he valued and what he was willing to pay for it. And that question is his to answer, not mine. What I can tell you is that in 4 years of thinking about this case, I have developed a consistent view about the specific moment when he said my turn. The view is this: he was not deluded about what he was doing. He was not acting without understanding the consequences. He assessed the situation, and he made a decision that the assessment supported by his own values and priorities. He looked at the situation and he said, "This is the situation in which what I can do matters." And then he did it. That is not irrationality. That is a very specific kind of clarity, the kind that comes from knowing exactly what you value and acting on it. I have spent 23 years in combat medicine. I have met a great many patients. The ones who know exactly what they value are the ones who are most likely to do what they have decided to do regardless of what the clinical picture says about the advisability of doing it. They are also, in my experience, the ones who recover fastest. I do not think this is a coincidence. I want to return to the moment of the cracked knuckles because I have been circling it throughout this lecture, and I think I owe you a direct address of it. Why does it matter? Why do I stop every time I get to it? Why is it in the case study rather than just the clinical findings that followed it? Because it is the most information-dense moment in the case. Not the richest clinically, the clinical findings are richer. The most information-dense in terms of what it communicated about the patient's state and intention. He cracked his knuckles. He raised an arm I had assessed as non-functional, and he cracked his knuckles with it. This communicated the following things simultaneously. First, the arm was functional enough for voluntary fine motor control. My assessment was either wrong about the degree of functional compromise, or he was accessing function at a cost I had not accounted for. Either way, the arm was more functional than my assessment said it was. That is clinically relevant information delivered without words. Second, he was aware enough of his own physical state to make a deliberate choice about how to present it. He did not simply get up. He made a specific, voluntary, deliberate gesture with the limb I had said was non-functional. He was communicating to the opposing force element, to me, possibly to himself. He was saying, "This is still working." Third, the specific gesture. Cracking knuckles before a physical engagement is a human behavioral signal with a specific meaning in their culture. I had to look this up after the case. The meaning is approximately, I am preparing to do something with my hands that requires significant effort. He was announcing his intention in cultural shorthand, to an opposing force that presumably did not understand the shorthand. For himself, I think. He was telling himself what he was about to do. That is what I think the cracked knuckles were. He was telling himself, and the telling made the doing more possible. The fourth implication, and I realize I said 3 earlier, but 4 years of thinking about this case has produced a fourth, is about what I am going to call narrative. Narrative in the clinical sense, not the literary sense. The clinical sense is this: patients who have a clear story about what is happening to them and what they are going to do about it recover differently from patients who do not. The story does not have to be accurate. It does not have to match the clinical picture. It has to be coherent, and it has to include an active role for the patient. Sergeant Okafor's narrative was, "I was injured, I am being treated, there is a problem at the treatment position, I am going to address the problem, then I am going to continue recovery." That is a narrative. It has a sequence, an obstacle, and an active resolution in which he is the agent. Patients with that kind of narrative, coherent, active, forward-directed, have better outcomes in my clinical experience than patients without it. This is not a fringe finding. It is in the mainstream literature, though it is more extensively documented in non-combat contexts. I'm asking you to bring it into your combat medicine practice. When you are treating a patient, find out their narrative. Ask them what they think is happening and what they think they are going to do about it. Not to correct the narrative, correct it only when correction is medically necessary. To understand it, because the narrative will tell you something about the biological trajectory that the clinical indicators alone will not. I have one more thing to say about Sergeant Okafor, and then I want to address your questions. This is the thing I have had the most difficulty incorporating into the academic framework of the case study, because it is not quite academic, and I think it is true. In all of my interactions with him, during treatment, during the engagement, in the brief period after the transport team arrived when he was insisting that I be transported first, he was never not human. I mean this in a very specific sense. He was in severe pain. He was seriously injured. He was doing things that were significantly inadvisable from a medical standpoint. And throughout all of it, he was a person. He was concerned about his squad. He made jokes. He said please when he made requests. He insisted that the non-combatant medic be evacuated first even though he was in worse condition than she was. He was, in the middle of the worst medical case I have treated in 11 years of combat medicine, paying attention to the people around him. I have tried to explain this in clinical terms and I cannot fully do it. What I can say is that it changed how I practice. It changed what I pay attention to. It made me a better physician because it reminded me, in the most concrete possible way, that the person and the patient are the same thing. You do not treat the injuries and then deal with the person. You treat the person, which includes the injuries. Sergeant Okafor did not give me a choice about this. He was fully present throughout. He was always a person at the same time as he was a patient. I try to remember that every day. I try to give every patient the same thing he gave me, full presence. That is what the lecture is for. That is what the module is for. That is what we are training for. To see the person and treat the patient simultaneously. Sergeant Okafor made sure I could not do otherwise. I am grateful for that, even though it was one of the most difficult professional experiences of my career. Questions? Yes, you in the back. I want to end this lecture with something personal rather than something clinical. I was in that treatment position. I was there when he sat up. I was there when he cracked his knuckles and said, "My turn." I want to tell you what that was like from the inside. Not the clinical inside, the personal inside. I have been in combat medicine for 23 years. I have seen things. I have seen beings do things that I would have said before seeing them were not possible. I have updated my priors many times based on things I have seen. The 30 seconds I take in the middle of this lecture is the 30 seconds in which I return to the treatment position, and I remember what it felt like to watch something that I had assessed as unable to do what it did do what I had assessed it was unable to do. What it felt like was a shift in my clinical framework. in my understanding of what the word impossible means in a medical context. I had assessed that arm as non-functional. He raised it and cracked his knuckles with it and said my turn and then used it for 2 minutes and 40 seconds. My assessment was not wrong about the damage. My assessment was wrong about what the damage meant for what he would do next. That is the shift. That is what I want you to take from this lecture. Your assessment describes the damage. The patient decides what the damage means. Your job is to give the patient the best possible biological conditions for that decision. His decision that day was, my turn. Your job when you face a patient who has made that decision is to have done everything possible to support the biology that makes the decision executable. I have been trying to do that since the treatment position. I have not always succeeded. I keep trying. That is what this module is for. You are dismissed. I will see you in clinical practicals next week. The question and answer section that followed the lecture has been partially transcribed here because Dr. Vel-Ka-Rath's responses to several of the questions expand on points made in the lecture in ways that she considers part of the case study. Student question: you mentioned the 30-second pause. Is that involuntary or deliberate? Doctor: Vel-Ka-Rath. Initially it was involuntary. It happened the first time I gave this lecture because I reached that point in the description and found I could not continue immediately. The image is very present for me. It is the image I return to when I am having difficulty with a case, not because it is comforting exactly, because it is clarifying. When I am having difficulty with a case, I think about what it felt like to have my clinical framework revised in real time by a patient who had decided something, and it clarifies for me what my job actually is. So the pause became deliberate. It is a teaching moment now. What the students do in the 30 seconds is as instructive as what I say in it. Student question: how do you separate clinical recommendation from respect for patient autonomy in cases like this? Doctor: Vel-Ka-Rath. You do not separate them. They exist simultaneously. My recommendation is part of the care I owe the patient. His decision is part of who he is. Both things are true. I give the recommendation because it is medically sound and because he deserves to have the best medical information available when he makes his decision. He makes the decision because it is his to make and because he has information I do not have, specifically what he values and what he has decided. The two things are not in conflict. They are both necessary. Student question: what happened to Sergeant Okafor after? Doctor: Vel-Ka-Rath. He is still active duty. He has been active duty for the 4 years since the engagement. I had occasion to see his medical record approximately 6 months ago in the course of a different case. His record shows one note from his treating physician at the surgical facility that I want to read to you because it is the best summary of the case I have encountered. The note says, patient presence for follow-up examination at 14 weeks post-injury. Patient demonstrates full functional recovery of all affected systems. Patient reports no residual limitation in any area. Physician note: recovery timeline and outcomes are inconsistent with injury severity at time of initial treatment. Patient states he had things to do. This is documented for the record. End of note. He had things to do. That is in his medical record. I think it is the most accurate clinical documentation of this case that exists. Student question: do you think you would do anything differently if the same situation happened again? Doctor: Vel-Ka-Rath. I would take the same clinical actions. They were appropriate. I would also pay closer attention to his statement that he needed to be back out there in 30. Not because I would honor it, I would not have approved it and I would not approve it now. Because that statement was the most important prognostic data point in the intake assessment and I did not recognize it as such. I would recognize it now. I would document it as, patient has expressed recovery intention. This is prognostically relevant. I would plan my treatment sequence with that information incorporated. That is what I would do differently. The medicine would be the same. My relationship to the patient's intention would be different. The case study has been published in the Journal of Combat Medicine and Xenobiological Practice under the title, Human Biological Resilience in Combat Conditions, a clinical case study with implications for multi-species practice. It has been cited 437 times in the 18 months since publication. It is currently the most cited paper in the journal's biological resilience category. Dr. Vel-Ka-Rath has received correspondence from physicians and researchers in 31 galactic medical facilities who have had similar experiences with human patients and who felt, before the paper was published, that their experiences were too anomalous to be documented. Several of them have submitted their own case studies since, which are in various stages of review. The emerging body of literature on human biological resilience is the fastest-growing subfield in xenobiological medicine. Dr. Vel-Ka-Rath chairs the subfield's newly formed research committee. Sergeant James Okafor was contacted by a research assistant working on a follow-up study to the original case. He agreed to an interview. The interview transcript contains one exchange that Dr. Vel-Ka-Rath has requested be included in the case study addendum. Research assistant: when you stood up and said, "My turn," what were you thinking at that point? Sergeant Okafor: honestly, not much. There were 3 of them and the medic was there and she needed to not be in that situation, so I stood up. Research assistant: were you in pain? Sergeant Okafor: yeah, a lot. Research assistant: were you concerned about your injuries? Sergeant Okafor: I figured I'd deal with that afterward. Research assistant: were you confident you could handle the situation? Sergeant Okafor: no, I was hoping I could. There's a difference. Research assistant: what was the difference in that moment? Sergeant Okafor: hoping you can is when you have not figured out yet whether you can. You find out by doing it. I did it. I found out. Research assistant: and the arm, the one that was assessed as non-F. Functional. Sergeant Okafor: the arm hurt, but it worked. I needed it to work, so I used it. Research assistant: the cracking the knuckles, what was that? Sergeant Okafor: force of habit, I guess. I always do that when I'm about to do something difficult. It helps me focus. Research assistant: did it help? Sergeant Okafor: yeah. End of interview excerpt. Dr. Vel-Ka-Rath's note on the excerpt: force of habit. He cracked his knuckles because it is his habit when he is about to do something difficult. He has always done this. It was not calculated, it was not a performance. It was the thing he does when he is about to do a hard thing, and it helped him focus. The habit and the focus and the hard thing and the biology that follows the decision, that is the whole case. That is what human biological resilience looks like from the inside. A habit, and then the thing. The lesson in this story is the lesson Dr. Vel-Ka-Rath has been teaching for 9 semesters and has not finished processing in 4 years. The lesson is about the gap between assessment and outcome. The assessment describes what is. The outcome depends on what the patient decides. These are related, but they are not the same thing. A sufficiently clear assessment of damage does not tell you what the patient will do with that damage. It tells you what the damage is. The patient tells you what they are going to do about it. And what Sergeant James Okafor told the treatment position and the opposing force element at the edge of it was 2 words. My turn. 2 words that required a decision. A decision to get up when getting up was not advisable. A decision to use an arm that had been assessed as non-functional. A decision that the biology, given the decision to make, found a way to support. The body follows the decision when the decision is clear enough. That is not mysticism. That is a documented clinical finding in human medicine. The decision was clear. It was 2 words. My turn. Drop 1 word in the comments. Whatever this story did to you, I am reading every single one. Subscribe to UG Human HFY. The next story is a completely different voice, a completely different angle. Every story is its own thing. That is the promise.